In this short video, I'm going to try to demonstrate the mimicking of airway pressure release ventilation in the flow-eye anesthesia delivery system. So as you notice, I'm just going to put in, I started with volume and control ventilation, and these are pretty much generic ARDSNet settings for a patient with ARDS. My test lung is the resistance set for 5 centimeters of water, and the compliance is 20. So the pulmonary mechanics are similar to an adult patient with ARDS. And these settings are if you're targeting a tidal volume around 4 to 6 cc range. So if people 10, a higher respiratory rate to make up for the minute ventilation and tidal volume. So I'm just going to go ahead and I'm going to start the case. And I'm going to start letting the waveforms scale on their own once I start the case. And we're going to look at our measured values here based on our settings. So I'm getting my exhale tidal volumes pretty much close to exactly what I have it set. I have a little leak in the system, so my exhale tidal volume is a little lower. And you notice our peak pressures are 31, minute ventilation 11 liters per minute. So if I go to screen 2, my compliance is approximately 19. I'm generating a mean airway pressure 18 and my plateau pressure is 31. So I'm going to look at this plateau pressure and use this as a baseline for setting my pressure control level. And we can consider this P high. So I'm going to set my pressure control at 30 centimeters of water. And I'm going to decrease my respiratory rate to really extend my inspiratory phase to maximize my IE ratio. And I'm turning my PEEP down to 0. So this is only one way to set a P low or a PEEP phase. So here's my IE ratio. And I'm going to change the rise time so I don't have it pressure overshoot, especially since I have a high pressure control level. So I'm just going to turn this up and evaluate waveforms to see if it's fast enough. I'm going to accept my settings, and we're going to check out our measurements and our waveforms and everything else. So as you notice right away that with the inverse ratio ventilation, I do have a very prolonged inspiratory phase. So this is similar to airway pressure release ventilation. My mean airway pressure has come up to 25, and as you notice, my exhale tidal volume is actually increased. So I have a higher exhale tidal volume, so I'm going to have to titrate my pressure control level and possibly my PEEP level. So I'm going to go back to pressure control. To give it to my settings, I'm going to change my inspiratory rise time, and I'm going to make it faster. So in my release phase or my expiratory phase, to get to a quick P high phase, I'm decreasing my pressure control level, or P high if you want to call it that. And this is decrease the tidal volume, and I'm going to increase the PEEP, 1 to gain more mean airway pressure, and 2 to decrease my exhale tidal volume. So as you notice that my changings, my exhale tidal volume are getting more in that lung protective range by 4 to 6 cc's. Now the main difference here between a traditional ICU ventilator is that if we look at the phase, the expiratory phase, this would be considered the release phase in APRV. And with airway pressure release ventilation, this release phase is very short. So it's usually under 1 second, anywhere from 0.75 to a half a second. So these are general, even down to a quarter of a second, to optimize lung recruitment and preventing a de-recruitment phase. As you notice with this stiff compliance, the lung completely empties and the volume returns to baseline or the flow. So there is no auto PEEP generated at all. So this is consideration for practitioners who like to set a T low. I do not have a T low setting, but to set a release phase to target a measured peak expiratory flow rate between 50 to 75%. So that I cannot do with this machine. However, there's 2 other ways to set your T low, and it's we can't really set a T low. But one is to titrate a T low to generate target volumes of 4 to 6 cc's per kilogram of ideal body weight. And we can manipulate our PEEP to do that. And that's the third way to do it. You're setting a T low to 4 time constants so that you have total exhalation. So we do have total exhalation. There's no generated auto PEEP at all. And then you manipulate your PEEP to get your exhale tidal volumes in your 4 to 6 range. So we do have that. Now, published in the medical journals, not one way is superior. However, through bench studies and mathematical models, they found out if you allow for complete exhalation, you do not have auto PEEP, and by manipulating your PEEP level, you have more consistent exhale tidal volume. So you don't have large overshoots of exhale tidal volume, and it's more in the lung protective range. So this is trying to mimic airway pressure release ventilation with an anesthesia machine. The Flow-I also has an added benefit, is it does have an active exhalation valve. So I'm going to demonstrate that in the next video, where the patient can always breathe on top. So that's the true heart of airway pressure release ventilation. The patient can spontaneously breathe anywhere in the inspiratory or expiratory phase. So you have unhindered spontaneous breathing. So I'm going to go ahead and show that.